The following program was produced by an independent community producer. The opinions expressed do not necessarily reflect those of the Weymouth Community Access staff or its board of directors. WCA, in compliance with FCC regulations, is prohibited from exercising control over the content of independent member-produced public access programming.
Thank you for coming. Dr. Everett, as I said before, you are a household word. I've heard about you for years, and you reminded me that you had been a guest 20 years ago, was it? Yes. Oh my God. Well, it's been 28 years, I think, we're doing the show, so it doesn't... tell us, everybody knows who you are, but introduce yourself.
Well, my name is James Everett, and I'm a medical oncologist, and I am one of the physicians at Commonwealth Hematology Oncology. I'm also a member of the South Shore Hospital medical staff, and I have practiced in this community now for 35 years. My office has always been in Weymouth, and I've always admitted my patients to South Shore Hospital. I'm also the medical director of Hospice of the South Shore. Hospice of the South Shore started approximately 30 years ago, and one of my colleagues and I and two nurses thought we should have a hospice program, and so we got one started. And so it is now very mature and very active and an integral part of the community, as the Walk for Hospice would demonstrate every year, when thousands, literally thousands of people come and participate in that fundraising event.
Dr. Everett, I asked you before, if I came back in 50 years or 100 years, well, you give me a pill and I'll walk out the door. And you said no, you think it's something we'll always struggle with.
Well, I think cancer is something we will always struggle with, because the cancer comes from within ourselves. It's not something, there may be environmental factors that influence the development of cancer, but the abnormality develops within our own genes. And through the course of history, the genes don't change very much, and so the risk of developing cancer is always going to be there. And as the population ages, since cancer is a disease of older people, there's going to be plenty of new cancers diagnosed in the years ahead. But
you could keep me alive longer than before.
I think we've made great advances in the treatment of cancer in the last 20 to 25 years. I have the perspective of having been around long enough to remember what it used to be like to try and not only treat the patients with whether it be surgery, radiation therapy, or chemotherapy, but try and take care of patients who were dying of cancer with the medications that we used to have in the old days for hospice care. We have made huge advances, so we can keep the patients alive, even though they might have metastatic cancer, for several years longer sometimes. I think the hope is that someday we will find treatments that won't make the cancer go away, but will turn cancer into a truly chronic disease, say the way HIV has been turned into really a chronic disease. Not that some people don't still die from HIV, but the majority of patients who take their medicines live with the disease. And so that probably is the most realistic goal for us as we look into the future. Which
isn't a bad goal, and I will turn to your colleague. And I have to tell you, and want to introduce yourself.
Hi there, my name is Sciascia, and I am a family doctor at Harbor Medical Associates in the Stetson building right down the street. And as background information, I had been in a private practice for a few years and then transitioned over to South Shore Hospital, where I worked as a hospitalist. You may have heard of that term.
And explain it for a bit. So what is a hospitalist?
A hospitalist is an acute care physician who takes care of patients only in the setting of their hospitalization. So there are a lot of initiatives going on right now at South Shore Hospital with that program, and improving communication, streamlining the care, transitions of care from home to hospital, and then possibly to rehab facilities and then back home again. So I did that for a few years, and then I've transitioned back over to primary care at Harbor Medical now. And I see people of all ages, including even some babies, right through people at the end of their lives, which is part of how I got interested in this topic we're discussing today.
So your practice isn't just for older or younger, or it is encompassing.
Exactly. That's family medicine is basically what people think of when they think of the old general practitioner, only that the training is several years longer than to become a GP. And we see people of all ages, and that's a part of what we like, the variety of what we do.
And isn't that interesting, because my primary only sees older. I mean, is that some people do?
Some people may be an internist. Generally, internists see only adults, and then there are some internists who are actually geriatricians.
Okay.
Either an internal medicine physician or a family physician could also get additional qualifications to become a geriatric specialist, and those are people who only see senior citizens.
All right. Well, I guess that's what I am, and that's who she sees. But I have to tell you how I admire you. And I guess it ages me to go back. In my day, there were only male doctors. And I think the field of medicine is so exciting. I see so many women, and I said to you, gee, you look so young. And you said, believe me, I'm old enough. But I think it's a compliment. I meant it as. I think bright, beloved, beautiful. It's wonderful to see women in so many fields, and especially in the medical field. And you said you didn't know if you wanted to be a doctor till, what, college?
Till college. I grew up in Georgia and then came up here for college at Boston College. And while I was there, I had a very wonderful mentor of a psychology professor who did a lot of teaching on the biology of psychology, and I decided I'd like to learn more about the human body, and really the best way to do that seemed to be to pursue the pre-medical curriculum. And at the end of all of that, it made sense to go to medical school, and I went in thinking I'd be a family doctor, and got sidetracked a little bit with neurology, decided neurology sounded really interesting.
And what is neurology?
Neurology is basically about treating the brain and nerves, treating things like stroke and Parkinson's disease. There are many different things neurologists treat. But in the end, I had a family medicine rotation and just decided I liked the variety better, and made that decision.
And how many years to become a doctor and to go into different fields? And today, what brings us here, Dr. Everett? What are we discussing this time, 20 years later?
Well, we're here today to talk about the concept of decision making, which we have called a fork in the road, for patients and their families, but particularly for patients who have an illness or a series of illnesses, who have to make decisions about what their goals are for the future. So in the context of that decision-making process, which the patient and the family and the physician sit down and work out together, we're also going to talk about this new concept of palliative care and the older concept of hospice care, which is also palliative care, but the new concept of palliative care is much broader than the old term of hospice.
See, hospitalist was a new word, and palliative care is a new word. So what does that mean for people like me, lay people looking in?
If I may, I
Yes,
can read
please.
the definition of palliative care
Yes.
to be sure that I am very specific about it. And this definition came from an article in Cancer, which is an oncology journal from August 2011, so it is really only 2 months old. Palliative care is focused on the relief of suffering, the treatment of symptoms, and the overall support of patients and families at any stage of illness. Palliative care is applicable to medical illnesses of all types. As an approach, palliative care includes hospice, but it also serves a broader population of patients, including those receiving disease-modifying therapy and those who have a prognosis of more than 6 months, who are generally not served by hospice care.
Okay, that makes it pretty clear. Reading that and all, what is the next step? How does that get into play? How do you implement that?
Well, people and patients and families should think of palliative care as a component of a program working with the patient to keep them as well as possible, to minimize symptoms and any suffering as they go through illnesses, treatment of the illnesses, complications of the treatment of illnesses. So in years past, hospice care for the most part was for cancer patients when we started the program here at South Shore Hospital and on the South Shore. Now only 35% of patients in hospice are cancer patients.
Oh, I didn't know that.
So the other 65% are patients with other chronic medical illnesses who in the last 6 months of life become eligible for hospice care, but prior to that 6-month moment would be eligible for palliative care, which would be an effort to treat suffering, treat symptoms, sit down with the family and say to the family and to the patient in particular, what are the goals that you have for the treatment of this illness, for your other illnesses, for the rest of your life. And it's a very sort of intense and probably somewhat time-consuming endeavor on the doctor and the patient's and the family's part, and it requires a lot of soul-searching, I think.
Do you agree with everything Dr. Everett has said? Are you coming from this a different
Maybe a slightly different perspective. The goals are the same. Often what I see in clinical practice is a situation in the outpatient world where a patient has a disease that will eventually become end stage, whether it be congestive heart failure, which many people don't understand as a diagnosis and don't realize the implications of necessarily. A lot of people equate congestive heart failure with the heart stopping, which is not the case. And we also...
What is it? Is it COPD?
That's a chronic lung disease, which also can be a terminal disease, you know, in certain cases. But oftentimes what we see is a patient who walks into the office who has a multitude of medical problems, frequently taking a multitude of medications, often experiencing side effects from their medications, interactions with their medications, treating the side effect of one medication with yet another medication, getting sedated from their medications, having falls, memory loss, a lot of these issues that can impair their safety in the home and lead to a lot of fires to put out, a lot of crisis management. And it can be very stressful for not just the patient, but also their family. Oftentimes there are family members who are trying to juggle their own responsibilities with their own families, with an elderly relative's needs. So even though you might have a visiting nurse association involved, you may have some other services through either elder services or through another agency. But it tends to be a stressful situation for the whole family, and it's rather insidious how it can creep up. So in the medical setting, in the primary care, sometimes we'll have a patient who walks in with a relative, and I can tell by looking at them that everybody, usually the family more than the patient, is stressed out about what's happening.
Yes, yes.
And frequently the patient may have Alzheimer's disease or some form of memory impairment where they don't completely understand what's happening with their medical care. They frequently don't know what medications they're on or why they're using them. It's rather overwhelming. So when you see the same patient back over and over again over time, and you realize that the goals of their care may not be in line with what their family and their physician think that they should be, it's time to sit down and have that discussion about where would you like your care to go. Would you like us to continue managing the crises? Would you like us to try to put out the fires? Are you more interested in treating the symptoms that are bothering you, even though you know your life may be shorter as a result of pursuing that option? And that's what I consider that transition to palliative care. It doesn't always mean enrolling in hospice care. It doesn't mean giving up medications. It doesn't mean you're going to be left out in the cold with no one paying attention to you and just assuming that you're about to die. It just means a shift in the purpose and the goal of treatment.
Well, what does that differ from what you...
No, I think that segues perfectly into the new concept of palliative care. Palliative care, I think, is more, it's a new field in every area, but it's more mature in the hospital setting. It is not particularly mature at all in the outpatient setting, but you can imagine with this philosophy that the palliative care physician and team has, that they could interact with the primary care doctor, the family, and the patient, help set the goals, go to the patient's home, try and make sure that the patient is following the prescriptions that the doctor's giving, for example, taking all their medications, to minimize the chance that they won't have a relapse, for example, of their congestive heart failure, and try and help the patient achieve the goals that they've set and help them stay in the home setting, if at all possible, minimizing the time going to the emergency room and ending up in the hospital. So palliative care, theoretically, should blend perfectly into this paradigm where there's such a need in the older population with all of these people who have chronic illnesses with lots of medicines and lots of symptoms, having them stay at home with their families help. So.
Now, has that not been happening? Is this a new concept? Is that happening now? Is that into play now, palliative care?
I would say it is to a minimal degree, to a certain degree, but not in a sort of comprehensive way. As I said, when the patients are in the hospital, there's more of a palliative care service and a palliative care team than there is in the outpatient setting. But the idea here is not just to set things up for the patient when they go home from the hospital, but to make sure that when they do go home, that the team is out there helping the patient stay as well as possible and be at home.
And does it matter when they're home, Dr. Everett, what did they decide? Is that, it's decision time, isn't it, when you give them all these things to think about? Do you want to say, I'm just going to take care of myself until the end, or I'm going to do this or that? Isn't it decision time?
Well, it's decision time, but the decisions don't come easily.
No, and how do you get to them?
That's fair to say.
Well, I can speak to that. That's a great segue to the idea of medical decision making and documenting your decision making. And what I generally advocate as the first line for that is for anyone who is either 65 or above, or who's living with a chronic disease, or who has dependents, to think about assigning a healthcare proxy. And for anyone who doesn't know how to find one of those forms, you can go online. If you just do a web search on Massachusetts healthcare proxy, there is an official state form that is a legal document. It's not the same thing as a living will. Okay. That is not considered a legal document in the state. Mm-hmm. The healthcare proxy is. You can download it, you can print it. Doctors' offices often have them, but they're easy to print on your own home computer. You sign it, you pick someone who you would want to make your healthcare decisions should you not be able to make your own for any reason. And
let me ask you this, who should you pick? Families are all over the country and the world now.
Whoever
so
you
if
want.
you have but I mean, say you have somebody who you really have faith in living in Florida, but when something's going to happen, a crisis, I may have another person here. Don't you have to make reasonable decisions too? This person I really want involved, but they're 400 miles away or 500 miles away. Should it be somebody in attendance?
You can choose someone as your primary and as your alternate on that form, and you'll need 2 witnesses. But as long as that person who's in Florida is reachable, everybody has a cell phone these days.
Right.
The globe is getting to be a smaller place. So it's not unreasonable that your first point of contact might be in another state. But what probably isn't feasible is having that person see you in your current state in the hospital to help make your decisions. Yes. So that's where an alternate healthcare proxy comes into play. So having assigned someone to be your legal decision maker actually can really solve a lot of potential dilemmas when there are multiple family members who may not all be seeing eye to eye on
and most don't.
Right, and the other thing that one can do to advocate for oneself is to make sure that the people who are your decision makers know what your values are. And I don't mean necessarily whether or not you'd want chest compressions or IV antibiotics or a feeding tube, not so much the nuts and bolts of the care that people might receive in the hospital setting, but what are your values and your goals? Does faith play a part of it? Is there an experience that you had in your life with another relative that has changed how you feel about healthcare and what you would or would not want for yourself? And if you sit down and discuss those things with other relatives or friends, then the person who makes your decisions knows where you're coming from. And it's all about being your it's substituted judgment. It's substituting your judgment when you're not able to make those judgments yourself.
So you have to really think about this long and hard. Who do I, because I may not be at that point able to express myself.
Exactly.
What I want. If I'm in second stage Alzheimer's, I'm not, you know, able to do what I would be if I didn't have Alzheimer's. So I really need to think long and hard about this. When you're talking with all these people, Dr. Everett, do you have any, do I have input? When I do a proxy, do I give away everything?
No.
No, okay. I wanted people listening to know that.
It's only activated when you've lost your decision-making capacity.
And who decides that? A doctor decides that? I've lost my decision-making capacity?
Yes, it's usually a doctor who would decide that, and frequently it's obvious, but sometimes you have to have a consultation with a psychiatrist to come in and evaluate the patient to decide whether the patient's capable of making their own decisions. It's, the responsibility that the family member, the healthcare proxy takes on is a very significant one too, because they're saying, that person is saying that if my relative can't make a decision for themselves, I know enough about what their wishes are so that I could act in that person's behalf. In other words, I wouldn't act to decide what I think is best for the patient. I would confirm what the patient had said they felt was best for themselves.
And doesn't the doctor have a lot to do with this? I mean, you're involved in sort of getting everything together and making sure it goes according to it's supposed to plan. I mean, are you involved in all of this? You in all the meetings and seeing the patient with everybody involved in this? Is it?
Well, I see the doctor as a facilitator in this situation.
Okay.
That our job is to bring the issue to everybody's attention, to advise and encourage people to talk among themselves about what they would like, what the patient would like for him or herself. We can give advice, sometimes by talking about the patient's condition and trying to give them a perspective of what the future holds. We can help them make a decision, but it comes down to the patient themselves with the family and the prospective healthcare proxy making the decision for themselves.
Okay.
And it's not always easy.
Oh, I would think it'd be hard.
Some patients don't even want to talk about it or think about it. Some families don't want to.
That's true.
Even in a crisis, the patient and the family don't want to think about it. And that is why concepts like palliative care and concepts of hospice are important, so that we try and avoid crisis management in these situations. We try and prospectively help patients to figure out what their goals are, what the future holds for them, and make judgments for themselves and on their own behalf on that basis. And sometimes it takes a number of meetings and a year or 2 years before you eventually come to have the patient really decide what they're comfortable with as far as healthcare proxy and end of life.
They've just told me we have about 5 minutes, but what I wanted to say is, what a mess. I mean, when you think about it, and I think this is the only way to go, to chat about it, to talk about it. I have 3 daughters. I know they would think 3 different things. So getting them together, good luck. With me sitting there, you know, not really being as alert as I'd like to be, or in a situation where this is a disease that could put the end to my life. So I think it's necessary, but it must be very difficult.
I would say if you haven't assigned a healthcare proxy, this would be a wonderful opportunity for you to think about that.
Yes, absolutely.
Today.
Yes, and I have assigned, but still that doesn't mean, even though this proxy has it, that the other 2, you know, wouldn't have their say. But I think it's the only way to go, because it makes the end better, or even if it puts everybody on the same page. This is what we're doing. Am I right? Or you tell the viewers about it for the last few minutes.
Well, I think that if a person has made a decision about end-of-life care and has a healthcare proxy, has a disease which they're dying from, there's a tremendous amount of peace of mind that goes along with having decided, knowing their ultimate fate, how they want to live the rest of their lives, short though it might be, and where they want to be. And if you think of goals, you know, we take care of elderly people, cancer patients and non-cancer patients, the two of us do, and we're always trying to help them sort of get to the last stage of life, and we're encouraging them, we're supporting them, and we're trying to give them insight as time goes by, and that's an important part of our job. And it's very gratifying for the physician because we can help the family set goals, and when you set realistic goals, you have something that you can achieve. So it's not a hopeless situation. It's not a despairing situation. It's a situation filled with hope because you have set goals that are realistic and achievable, and it gives the patient, the sick person, peace of mind, especially if they can stay at home.
I think it's wonderful. I want to stay at home eating chocolate and watching the Red Sox. And I think that would be very good for me, Doctor.
Well, make sure you tell your healthcare proxy.
I've already told them, and they know it, and truffles and M&Ms. But I think it's, and I absolutely, and I had a dear friend who had her family face this. It was the toughest part of their lives. And these are young women who had to face, and young men who had to face this about their mother who wasn't able to. And they did a lot of soul searching, a lot of meetings, and it was not a fun thing. And but in the end, it worked out nicely, and they made their decisions, and they kept to them, and it was peaceful. She was in her home, doing what she wanted to do. End came very nice. Hospice was involved, but it was not, and I urge people to listen to this, it was not without some difficulty in soul searching. And when you're not able to make decisions for yourself, very difficult. That's why you have to make them known. I agree with you. Run and get that proxy. So, and work with doctors. I think it's wonderful that you care about me and your patients to want to know that this will be an easy setting. Because nobody gets out of here alive, do they, Dr. Everett? I mean,
not that I'm aware of.
Not that we're aware of. So we never talk about death or dying. I mean, it's something we just go about our lives and figuring, not me. Well, anyway, what would you add? We have 2 minutes, and I think it's if all the shows I've done, I think this is very, not that they're all not good, but this is important.
Well, I would encourage the people who are listening to, as we have discussed, talk to their family members about their healthcare proxy and what their wishes would be. They should also raise the subject with their physician. Not all physicians raise this subject with the patients as time goes by, and I can speak for myself. I've had patients where I haven't talked about it as I've taken care of them for years, and all of a sudden one day I say, gee, have we ever talked about what your wishes are? And the patient would say no, and I'd say, wow, well, let's talk about it today. Much to my surprise, the patient would say, gee, I don't want any life support or anything like that, and so we fill out the form. But I think the point is that, that palliative care and hospice care really provide a foundation and a network of providers and caregivers, physicians, nurses, a team to help patients and families who are in this situation and want to stay at home and be at home.
And would you add to that, Doctor? Would you have anything?
Try to speak with your physician, schedule a visit just to discuss it. It's something to not, don't tack it on to the end of a 15-minute visit on 5 other issues. It deserves its time.
Excellent, excellent. I would go to, and we have to, thank you so much. Thank you so much for coming. It was a wonderful topic. We'll do it again.
Thank
Bye
you.
for now.
Thank you.
I loved it. Excellent, excellent.